Welcome. Let me first thank you for your commitment to being a hospitalist educator for the IU School of Medicine. We value your contributions and know how challenging it is to find time to teach our students and residents during hectic inpatient rotations. This is a brief 10-minute video developed to help you provide meaningful evaluations for our students. It is most effective if you intermittently pause the video to reflect on your own teaching experiences and practices. Think back to the last time you finished a tiring ward rotation and finally sat down to fill out end-of-month evaluations. Did you ever wonder what happens to these lengthy forms? Who is reading them? Whether you were providing the kind of information that was actually needed? On the flip side, have you ever had to write a summary letter for a medical student or participated in a resident competency committee meeting and found yourself frustrated with evaluations that seem grade inflated, contradictory to other evaluations on the same student, lacking any information other than what a nice person the student was? Our clerkship and residency directors need our evaluations to be more useful and meaningful to assist them as they determine who is ready to advance to their next stage of training. And by meaningful, I do not mean longer, I mean more useful. To maximize the impact of your evaluations, let's start with some basic information. I'll be reviewing some common missteps, introducing the frameworks that we use to standardize our evaluations, and finishing with some concrete tips to help you provide evaluations. First, what is evaluation? You may or may not have heard the words summative and formative to describe different types of evaluation. Formative evaluation is what drives feedback and describes dynamic, continuous evaluation used by the teacher to let the student know what to fix or repeat to form and shape in-the-moment improvement. In contrast, evaluation, as clinician educators use the term, describes a summative assessment which summarizes what the teacher knows about the learner's performance, usually after the teaching has already happened. Unlike feedback, which is used to spur immediate changes in student behavior, evaluation is most often used to document a student's reaching some level of competency. So, what kind of evaluation are you being asked to provide? First, let's point out what our clerkship and program directors are not asking for. Number one, you are not being asked to assign a grade. Rather than be disappointed by this, be relieved that someone else has the ultimate responsibility for this. Remember that your evaluation is one of many components that are all used to assign a grade. For students, grades for a clinical course are determined by multiple evaluations, exam scores, and performance on assigned exercises. For residents, to successfully complete their training program, they must be evaluated by multiple clinician educators across diverse specialties, prove procedural competency, and show satisfactory performance on other mandatory exercises. So remember, the clerkship and program directors who study the evaluations you submit need meaningful evaluations of substance rather than whether you think your student deserved honors or not. Number two, you are not being asked to curve your students. Resist the temptation to compare your students to each other, to others you've worked with in the past, or even to your own experience. While it feels good to write the best student I've ever worked with, be wary that grade inflation can sabotage the value of your evaluation. Also recall that your students' H&Ps should not necessarily resemble your own, as a busy hospitalist who probably has to rely heavily on acronyms and minimal explanation. Each evaluation should be its own objective assessment of your learner's performance. Number three, you should not feel like your student deserves a glowing evaluation across the board just because they were nice, hardworking, and punctual. They certainly deserve recognition for professionalism, but should not be excused for deficits in medical knowledge. Don't let a pleasant personality skew your evaluation. Grade inflation is academically dishonest and robs your learner of opportunities for improvement. Last, you should not feel like you are in a popularity contest where a glowing evaluation from you assures a grateful, glowing teaching evaluation from your student. Our job is to give an honest assessment of our student or trainee's abilities. Educational research has shown that faculty who were the tough graders were much more accurate identifying which students would go on to struggle. Hence, these were considered the evaluations of greatest value. So, now that I have reviewed some common missteps, what kind of evaluation do our educational leaders from you? They need objective evaluations on whether your student has reached specific educational milestones as outlined by frameworks. What are frameworks, and why do we need to use them? You have probably heard of different frameworks used by medical schools and training programs to ensure consistency and reliability of evaluations. You should know that while they differ in approach, they are similar in what they evaluate. Most importantly, frameworks are not meant to make more work for you, rather make it easier for you to evaluate your trainee by providing a standardized language to communicate your evaluation across diverse staff and settings. One framework that should be familiar is the ACGME's core competencies. To recap, these are patient care, medical knowledge, practice-based learning and improvement, interpersonal and communication skills, professionalism, and systems-based practice. This system is detailed and hierarchical, using broad competencies, sub-competencies, milestones, and increasingly objective and observable and trustable professional activities, or EPAs, that detail exactly what a resident needs to master during training. For medical students, we have developed institutional learning objectives, or ILOs, which are conveniently crafted using the same language of the ACGME competencies. Finally, we come to the RHYME framework, developed by Dr. Lou Pangaro. It is easy to remember as it resembles the familiar progression of clinical care rather than an itemized, sometimes abstract framework, such as the ACGME competencies. What does RHYME stand for? The first stage is the reporter stage. Your student has attained this stage when they can reliably and accurately gather and report clinical information. This data is collected from patients and other sources, is reported verbally in presentations, and is written as comprehensive H&Ps and daily SOAP notes. It is expected that a third-year medical student should be at this level. In the interpreter stage, your student has moved on to analyzing and integrating their data to develop and defend differential diagnoses. This stage also requires the maturation of clinical reasoning skills and judgment to be able to prioritize patient problems. Usually our sub-interns and interns should be working to achieve this level. Next comes the manager stage. Now your trainee is consistently developing diagnostic and therapeutic plans. Higher level clinical reasoning and communication skills are required to make this significant transition beyond observation and understanding into the realm of action. Typically, it is our second and higher level residents that should be performing consistently at this level. Finally, we come to the educator stage, which should describe not only our graduating residents, but also myself, you, and our colleagues. Our trainee has now proven to be a dedicated self-directed learner, able to self-correct and improve, able to share their newfound knowledge with colleagues and patients to teach and learn. Now that we have reviewed the types and purpose of evaluations, pitfalls, and frameworks, here are some helpful tips for completing evaluations. First, think about the expected objectives for your student. For example, don't expect to evaluate a third-year student as if they were an intern, or teach a fourth-year student skills expected of a senior resident. Sounds obvious, but don't forget that your teaching and evaluation should be geared to your student's level of training. Once you know what level of RHYME your learners should be achieving, be sure to probe whether they are getting there. For example, focus more on reporting skills for your third-year students rather than whether they can manage patients like a resident. Many learners are eager to prove they are functioning at aspirational levels, sometimes skipping over what they really need to be focusing on. Higher skill behaviors can be rewarded, but not before basic expectations for competency are met. Take detailed field notes on your observations of learner performance. Research shows this practice definitely improves the quality of evaluations. Keep note cards, email notes to yourself, whatever works for you. Consider writing the narrative sections of your evaluation first. These may be easier to complete while you have more energy before you have grappled with 30 buttons to click. Starting with the narrative may also sharpen your recollection of their performance and actually may make those 30 buttons easier to get through. Try to steer clear of comments on personality and stick with RHYME descriptions of objective work-related behaviors. Comments such as, "will be a great doctor" and "a great person" are next to useless. Instead, here are a few examples of meaningful evaluations of a medical student and a resident grounded in RHYME language. By the end of the month, John Doe was consistently taking thorough histories and physicals and was starting to use this information to form reasonable and prioritized differential diagnoses. Jane Smith has consistently shown mastery of history and physical taking, is comfortable managing complex medical issues, but needs more practice with self-directed learning skills by researching clinical questions rather than solely relying on her staff for the answers. Finally, be balanced. In addition to documenting levels of competence, your student or trainee will also read your evaluation, seeking formative feedback. Try to provide both positive comments to reinforce good behaviors and constructive comments with action items to improve on them. Still there? If so, thanks again for taking time to listen and reflect on how we'd like all of our IU School of Medicine hospitalists to be providing meaningful evaluations on our ward rotations. If you have any additional questions about meaningful evaluations, the clerkship and program directors are an excellent source of guidance. With active reflection and practice, providing meaningful evaluation will become one of your skills as a master clinician educator, and your students and programmatic directors will thank you for it.